I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Good evening, and welcome to another episode of Faisel and Friends. My name is Saeed Solomon, and I'll be your guest host today. Faisel has another commitment and he has asked me to host for tonight, which is always a privilege and an honor. Dr. Dan, are you around?
Absolutely, Say. It's good to be with you this evening.
Hey, Dan. Happy holidays.
Absolutely. And this is a great topic for the holidays. I know I had a patient, one of my patients in the emergency department yesterday, and the doctor from the emergency department was very helpful. So this is a great topic. That's
great. One of the mainstreams of our model is making sure that our patients are aware that we are always watchful of their care, regardless of where they are, more so when they are getting care outside our centers and especially in emergency rooms. So I think this is a topic that is very close to my heart and my day-to-day role within ChenMed. And we have the privilege to have Dr. Adam Perry on the show today, and he's going to be walking us through what is that partnership with an ER physician looks like, what is the current state of an emergency room when treating with the older adults, and what are the different ways that we can strategize together to be able to care for our patient population. So I'm extremely excited, looking forward to learn a lot from Dr. Perry. Dr. Perry.
Dr. Dan, thanks for having me.
Hey, Adam. It's a pleasure to have you here.
I'm thrilled to be here. Happy holidays. I hope I come with a message of hope in a transition and a communication between PCPs and the emergency department that always not always the most hopeful conversation. So I hope overall I'm going to shed some light and point towards a better future for communication and collaboration for our patients.
Which should be at the mainstay of the PCP patient relationship that's built around trust, but also in alignment and partnership when that care occurs outside of the center walls. Adam, you have a unique skill set that not a lot of doctors have. Can you just tell us a little bit what your background and your particular skill set?
Sure. So like our colleague Faisel, I trained as in an unopposed family medicine program. And immediately thereafter, my interest was in rural underserved areas. And I worked as an emergency physician for several years and sort of halfway between Jackson, Mississippi and Shreveport, Louisiana, doing 84-hour shifts and really learning emergency medicine. And I went back to Pennsylvania and worked in emergency medicine for 18 years. What I realized is I was really doing emergency geriatrics. I was working community hospitals, and I was taking care of complex older adults without tons of resources. And I figured I'd try to learn what I was doing. And so I went back and did a geriatric fellowship and was fortunate enough to get involved in development and dissemination of a model called the Geriatric Emergency Department model. And so practiced emergency medicine, full boat, and then got into that model and realized that the other part of that is primary care docs. And so just so fortunate to be here and hope to help our PCPs advocate for their patients.
Wow, Adam. So you're a Geri ER doc. That is not very common.
About that and $2 will get you a cup of coffee. You know what I mean? It's not, but it's not. They used to call me a unicorn. I was, the only person we know that did a geriatric fellowship and practiced full-time community ER. But hopefully this is hopefully I can lend some expertise that can help our patients. It's an unusual career path, to say the least.
But a well needed skill set, right? And the emergency room as you're overlooking the care of people that come in with acute illnesses. And sometimes that can be lost because, within that, because of just the dynamics of the emergency room, right? So I think it's important to, we're going to try to shed some light on the importance of this partnership between a primary care physician and an ER physician, and how to establish the next best steps early within the care of the patient to then, within the next level of care. So Adam, taking a step back and looking at the state of the emergency room, right? The emergency room on its own is this, well-oiled machine. Walk us through, if I'm a patient or my family member comes in through the emergency room, how does that look like in any typical day? And how does that translate into, an older adult's experience in the emergency room?
That's a great point. I think it's a great place to start, because I like to say that the emergency department is part of the continuum of care, but I think it's a critically important part of the care continuum, clinically and both financially, because as we'll talk about in a moment, the emergency department makes that very critical admission decision, and the decisions and processes they make affect length of stay for patients who are admitted, and so that can be a little frustrating for primary care docs who have a little bit of who work in a value-based system. The ER docs kind of in control of the purse in some way, and a massive part of the clinical outcome for our patients as well. But thankfully, a lot of the admissions are discretionary, and the ER docs want to talk to the PCPs to make the decision to send home if they can. How does that work, and what are the nuances of the emergency department, I think, as we start to develop a strategy and some real smart techniques? What I think I'm going to focus on today is really what's the highest risk group who really, really needs this care coordination. I'll talk a little bit about a slide that I put up, and then I'll talk a little bit about what happens when this patient population comes into the emergency department. So I sent a slide. Hopefully we can get it up. So this is, say you're very familiar with this. This is the trajectory of illness, chronic disease trajectory. And the important things here is on the y-axis is sort of level of activity or function. And on the x-axis or horizontal axis is time. And you'll see two horizontal bars. The first one there says IADLs, and the second lower one says ADLs. And the point of this slide in the context of this conversation is that older adults, with chronic illnesses, as you go forward in time, have multiple exacerbations, and each one of those dips is, say, a hospitalization or acute change in status. And an emergency department presentation often happens when an older adult falls below a certain critical level of function for their living environment. And then if you look on the far right, that shaded box, that's older adults with complex medical conditions and functional capacity below the level of independent living. So oftentimes these are people who need care at home, they're in a facility, and they're having frequent exacerbations without return to return to independent function. And that's the sort of population we're going to talk a little about and focus on today, because this is where repeated hospitalizations can really have some hazards. However, it's also where emergency department care is most potentially valuable, because older adults with complex medical problems often get quite sick and you're not sure why. They have atypical presentations. They're weak and they're dizzy, and that could be because they're weak and dizzy or because they've got sepsis syndrome. So long answer there, but setting the stage for the next part is what happens when an older adult like this comes in. Well, they come in by ambulance because they're functionally dependent. And oftentimes, the thing to think about is it's all about speed. So the ambulance will pick them up from wherever. Oftentimes, they'll draw labs. They'll land in the emergency department, and they get an encounter with a nurse. They'll hand off the labs. There'll oftentimes be a triage process that's triggered. This person had a fall, or this person had a change in mental status, and they might go right for CAT scan. The labs might be run right away. There's a pre-registration process that allows the labs to be done, but not necessarily run insurance. And I think for the purposes of this conversation, this incredibly efficient process enables the ER doc to walk into the room with the results of their CAT scan, their labs, some report from EMS, and make a disposition decision before the primary care doc even knows that the patient's in the emergency department. And that ER doc needs to make the decision about initial diagnosis and initial treatment plan, which as you know, sometimes changes if they're upstairs, but also now needs to make an admission decision, needs to make a disposition decision because they're on the clock. And that window between when that person lands in the ER and when that disposition decision is made is the most critical time period for our older adults, because the ED doc needs the PCP's information to make an accurate diagnosis, to make a goal concordant treatment plan. And if it's one of these hospitalizations that's potentially impactable, and we'll talk, there's an article that talks about variations in admissions. If it's an impactable admission, the ED doc needs to talk to the PCP, and they want to talk to the PCP. It's just not easy to do.
I love that you say that they want to talk, right?
Yeah.
Because sometimes the perception is, well, the ED's too busy. Right, Dr. Dan? I'm like, you've been in this, we've been doing this for some time, and do we really call the ER doctor? Would they want to call, speak to us? But it seems like based on what Adam is saying is the ERs are expecting, primary care doctors to reach out.
Well, and say, I think we ought to point out, I mean, one of the really cool things we have here is our ENS notification system. So we actually get I generally get the notification often before the patient has even seen the triage nurse. And so my usually first step is I call the patient to find out if they pick up on their cell phone and what's going on. And then the next call is to the emergency room. And so I had that yesterday. A patient of mine went to the local drugstore and he had a little weak and dizzy spell in the drugstore. And before he knew it, they had stuffed him in an ambulance and sent him over to the emergency room. And I called, and the emergency room doctor jumped on the phone right away. And he's like, started describing the EKG. And I said, well, would it help if you had the old EKG? And he said, oh, yeah. And what about a med list and a problem list and maybe the last labs? Yeah, that'd be really helpful. So we came up with a way to send it to him with, maintaining confidentiality and HIPAA compliance. So, yeah, he was very helpful. And then after a few hours went by, he said, well, I haven't found anything new. What do you think I should do with him? And, I said, well, I'm happy to, this is what I would do. And if you do that, then I'll do a video visit with him first thing tomorrow morning. And then we'll make sure everything's going well. So, I mean, it really, I would have liked to have avoided the ED altogether, but, really couldn't. He had had the weak and dizzy spell. He was there. They had to do their drill. So I wasn't telling them not to do their drill. But, I mean, it really was a collaboration about what to do for the patient. And I feel like the patient wound up getting the best possible care. My fear is always that the 80-year-old now gets admitted to the hospital. He's not that sick. Therefore, they put him at the end of the hallway away from the nurse's station. He sundowns in the middle of the night, gets up, breaks a hip. And then we're really off to the races if that happens.
So Dr. Dan eloquently, and I know this because I can vouch, Dr. Dan does that all that day in and day out, as most of our colleagues, most of our colleagues here at ChenMed do. I think in summing up what you both have said is, it seems like this all care of the older adult in the emergency room is centered around, trust, between the PCP and their patient, right? Their PCP reaching out to their patient reaching out back to inform. Once that connection is made with the PCP and their patient, that the PCP has done the triage piece of like what is actually going on, then the next step there is try to get ahead of the process and reach out to the emergency room physician to offer the support, the help that the emergency room physician needs to be able to make the next best step, or step of care for this patient, right? And just for a little bit of a parenthesis, for the folks watching or listening, feel free to send your questions into Dr. Dan. We're looking forward to answering your questions. But Adam, as you describe that trajectory, right? If let's say I get that ENS notification that we just mentioned, emergency notification that we have here at ChenMed. What should I have readily and available for the emergency room physician that once I'm able to get them on the phone, that they're going to need from me? Like that minute or less than a minute that I get their attention, what do I need to have in place in order to allow the emergency room physician to make the best decision for this patient?
So the first thing in working with the geriatric emergency department model at multiple hospitals, we realized the first thing that you need is a real process, because it's really great to call the emergency department. But there are so many moving parts, changing shifts. Emergency departments these days have 80 rooms. You don't know when your patient arrives who they're going to see. If it's a smaller ED, there's one doc, maybe you get a hold of them. People are running, it's like a beehive. So the first thing you need is a process and a system that PCPs can communicate with the doctor who's taking care of the patient quickly. And that's not a process that you and I as PCPs can readily make. We found that it's often an administrative or leadership type agreement between administrations and EDs and staffing models to find shared incentives. So shared incentives might be, we'll pick the patient up, or, we can talk a little bit about finding shared incentives. But I wanted to stress the first thing you need is a system where every doctor calling that ED from ChenMed or from whatever group, there's a way to get a hold of them. Because each time you're reinventing the wheel and you're going to talk to the charge nurse, and you know how that works. Yeah. So once you've got a process, you've got a smart process that you can track who's calling, how often they get a hold of them. This is like a QI project. So once you've got that set up, now you're talking to them, and you need a few things. You need information they need clinically. And that is, just like Dr. Dan said, what's their baseline? What's their acute change in status? Why are they there? Now you're using the emergency physician as a consultant. It's like your most expensive consultant, and you didn't choose he or she, but you're using him as a consultant. This is the acute change in status. Their baseline cognitive status usually is X. Today they're Y. This is what happened last time. So baseline cognitive status, baseline functional status, their support network at home. Like, are you going to be able to provide this for, have this person go home if you don't have any acute inpatient needs? And most importantly, for this coordination and care conversation, this is resources and risk reduction that I can offer you as a safe alternative to hospitalization. Because the ED doc, particularly in the age of COVID, without case managers, social workers, they can't make a safe alternative to disposition quickly. But value-based primary care physicians can, just like Dr. Dan did. I'll see him tomorrow. I know him well. I'll call their son or daughter. And ER doc says, that's great. You're Dr. McCarter. Dr. McCarter says, see him tomorrow. Baseline functional status. Everybody wins. Everybody wins.
Everyone wins. And that to us is very important, right? Yeah. The patient wins, the system wins when it comes to good allocation of resources. Yeah. But before we go, Dr. Dan, you wanted to add something?
Well, I was going to say, Henry Soderberg joined us. He joins us fairly frequently, mm-hmm. and he's asking, how do we make this timely exchange systematic? Or maybe to use the Don Berwick phrase, what would we do by next Tuesday morning? What would be the first thing to do by next Tuesday morning to get this more systematic so we can improve this communication?
And let's hold on into that question and just let our sponsors give us a quick message. See you guys in a few seconds.
ChenMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chenmed.com/physicians for more information.
And we're back. Henry, thank you for your question. And going back to Dr. Berwick's point is, Adam, how can this happen tomorrow?
So it's just like finding any other consultant. You start with finding the right consultant, and then you find shared incentives. And that's why I think full risk value-based care is the entity that's going to sort of crack this puzzle. In the fee-for-service world, this isn't something that finding shared incentives is that possible. So what do I mean by finding the right partner? There's good data. We all know who practice this. We sort of know it intuitively, but there are massive variations in admission rates between hospitals and between providers in the same hospital. And very importantly, ED docs work at a bunch of different hospitals. I've worked at dozens of hospitals and oftentimes many at the same time. An ED doc will admit, say 40%, which is the average for older adults in hospital A, but 55% in hospital B, the same ED doc. So we think that a lot of the variation is certainly provider to provider variation, but a lot of it's hospital variation. So try to find hospital partners, if you can, who aren't as interested in admitting your patients. And you'll know there's variation across the board. The second is, once you find the right partner, find shared incentives. We talked about that. It might be, we'll pick the patient up. We value care or coordination. So potentially ways to value care coordination, develop relationships with the administration or the ED staffing company. And then develop smart, replicable, simple ways to contact the emergency department. And that's a shared, I worked with a group one time. What they do is they put a red phone. They had preferred SNFs, right? And it was an ACO. So they had all these readmissions from the SNF, and it was an ACO. So no one, everybody was on the same page. So the medical directors of the SNF said, here's a red phone. We're going to call you. You got to pick it up just like it's an ambulance squawk box. And that worked. They had double-digit reduction within months, but they systematized it and they incentivized everybody. Otherwise, you're just picking up the phone and you're calling a place with 80 beds. And that's so frustrating to primary care docs. So frustrating. And it's frustrating to the ED doc, because when an ED doc talks to a primary care doc, they don't know that they're value-based. They're used to talking to fee-for-service docs who are like, why are you calling me? In so many words. Yeah. In so many words.
Adam, thank you. You know what? I think that's achievable. Maybe not in a day or two, but it gives me hope that what you're saying is that the key thing is, one, identifying the right provider, leveraging utilization data, and two, finding the right incentives and the system that's able to I would say partner with you on those incentives, where we're adding value to the entire care coordination equation, right? So we need to be able to give something to that ER doctor that they're comfortable in disposition that patient, back to the care of our primary care docs. My own experience with ER physicians calling, you have to be able to call the right number, right? I like to call it the red phone in the back. Like, that's the number I would want. But also, how can you deploy the resources in an effective time to be able to allow that disposition safely to the emergency room, right? And transportation, I think, being one of the most common ones that we encounter, right? That patient is able to get there easily by EMS, but maybe not as easy for them to get back home.
They can't get home.
Right.
Dr. Dan made a great point, and you just hit on it. Like, it's so hard to find the person that you're looking for. And Dr. Dan made a great point. You call the patient, which is, if the ED doc's in the room, that's great. But one thing that I used to do, and PCPs who I knew, they would call the patient, leave a video message. Hey, Dr. Perry, it's Dr. Jones. This is my patient, Mrs. Smith. She has been in an assisted living facility. She's fallen 4 times in the last week. I think she's had a low-grade fever. She has a history of, abscesses. So using technology to embed a video was something that was actually pretty useful, because then I could just see that and say, oh, it's Dr. Jones. Let me call him. Because sharing information is helpful for diagnosis, but conversing and coordinating care is where you offer the safe alternative to disposition. And you can't do that with a stack of paper.
So humanizing the process, right? Building that relationship between providers that is centered around the care of the patient. I love it. I love it.
Yeah, I love the idea of never thought about sending the video, but I mean, that's great. You're right. They could just, you could put a little blurb about the patient and then they could just play it for the doctor when they come in, and that might um, give them the information they need. Now, you shared the article with me that you were showing that showed that there was more variation between hospitals than there was between doctors. And there was there was at least one line in there, and I've got to say I read it pretty quickly, that was saying that there seemed to be a difference between, especially between rural hospitals and urban hospitals, and you've worked in both. So why do you think rural hospitals have a lower admission rate than urban hospitals?
Off the top of my head, I would think two things. One is just this challenge of finding the ED doc. My last several years, I worked in a single coverage ED, 12-hour shifts, only doc, knew the docs in the community. I would call them and they'd talk to me because they couldn't get away from me, right? I was the only person there. So that helped with care coordination. One of the challenges is, as an ED doc, I wouldn't know who is, say, a ChenMed patient and who wasn't. So that's why embedding the video is one idea, because the ED doc may want to talk, but they don't know who's in value-based care. The second component is, in a larger hospital, there might be more time pressure. And that, in a smaller hospital, you might have 4 or 5 hours to coordinate care, call family members, try to get transportation. In a hospital that's constantly under time pressure, it's admit them and they'll figure it out upstairs, which then just creates this time pressure in the first place. But those are two reasons: ease of direct communication and time pressure, which drives admission and long length of stay admission.
So that time constraint, right? So the efficiency of the involvement of the PCP reaching out, there's a specific time that needs to occur, right? So if that notification comes through, that notification is stop what you're doing. The clock has already started, right? So sometimes, we were at our offline, it was, sometimes we get that notification, but that notification could be after even almost at the point where a decision is being made to what will be the next steps, right?
Absolutely. I think that the terms we use are available and accountable. And I know, in the last places I worked, I would walk in the room and everything is done. And then it's just a matter of really making a decision. But, we talked about what kind of systems you develop. I think a lot of this is you got to incent the PCPs as well. We count, everybody has metrics, and maybe that's a metric. How quickly do you make the call may not be, but how often do you call? How often do you treat the emergency like it's an emergency, which is, one of the things obviously that ChenMed does so well. But I agree, you have to incent that, and you have to do it. It's an emergency. You have to do it right away. If not, then, they're admitted, and then the rest of that story.
Which adding a little bit to that, once they're admitted or about to be admitted, the ER physician is the one determining, for the most part, the overall management, right? So that doesn't have to say that you should not reach, if you can't reach out at the moment that you get the notification, you still have to reach out, because for the most part, that ER physician is the one making the establishing the plan of care going forward, which, if it's not the right one, can definitely prolong length of stay, increase utilization, and unmask, one of the most common iatrogenic things that occur in a hospital, right? Medical errors, delirium in the older population, right? Which to me is why this is so important. Like, being able to communicate, effectively, allows us to avoid a lot of these things that happen to our seniors in hospitals, right?
That's a great
so I think
point.
This partnership is essential for the overall care of our patients. Dr. Dan, any questions from
I think.
No, I mean, Henry makes another comment. He said, I'm thinking I might visualize the ED to primary care process you were describing, both as it is, path of least resistance admitted, and as it should be, safe and timely discharge to primary care, additional info for inpatient care. So, yeah, when you were describing, and when you were describing the having to make a decision and move quickly, it reminded me of something I saw on the internet the other day. I think it was a saying from the Navy SEALs that slow is smooth and smooth is fast. And so when you're you know when we're taking care of patients, the average age is 72, they average 5 or more chronic medical conditions. Many of our patients can walk into any hospital on a good day and get admitted to the hospital. And, we know there's about a 1 in 200 chance of dying anytime somebody gets admitted to the hospital. And, medical error is the third leading cause of death. So if we can intervene and help slow things down just a little bit to have 1 second thought that maybe there's another option, maybe that is actually adding some value to the patient as well.
You make a great point. That's one of the points I wanted to make is certainly you want to impact and prevent avoidable hospitalizations, and you want to decrease length of stay by setting the right trajectory and avoiding delirium and avoiding medication errors. But in some ways, the best way to avoid admission to the hospital from the emergency department is don't send them to the emergency department. And of course, ChenMed's excellent at that. But there are emergency department alternatives, and this is a massive and growing field. And I just wanted to, I gave, maybe they could put it in the chat, but there's a few really interesting models of non-hospital based expedited acute care for complicated older adults where triaged appropriately, they can get infusions and CAT scans, observation level treatments, and long evaluations that in treatment for unmet palliative care needs, consideration of goals of care, all the excellent patient-centered care in an unhurried environment. And so those are sort of springing up and always in a value-based setting. Additionally, there's community paramedics. Some places are sending community paramedics to the emergency department to try to facilitate this conversation. There's a lot of ways to avoid the emergency department. Those are two new ones. Additionally, there's home-based urgent care models with large providers we all know about, and then there are emergency departments that may be more interested in this. There are accredited geriatric emergency departments. There's about 300 in the country, and hopefully there'll be a link to that in here. And now there's several dozen age-friendly healthcare systems, and so those might be valuable partners to consider. So those are just some other ideas.
So it seems, Adam, that if I'm a PCP listening and I'm trying to think like what would be the three overarching messages of this conversation is, one, the importance of having a relationship with your patient, like open the lines of communication once that patient touches the emergency room. Identifying the right ER physicians that are able to care for an older adult in this setting. Identifying the right systems that are able to partner with a primary care physician in the care of their patient whilst they touch the emergency room. And 4, knowing that there's a lot of different novel models out there that can serve as an alternative to the emergency room, right? As and you mentioned a few of them. So, I think after this conversation, I'm pretty hopeful that, we would be able to, provide the best quality care for an older adult in an emergency room setting, in America. What do you think?
I think that's a great summary. And I started by saying I wanted to have some hope because I know this conversation has been so frustrating. It's almost like a nihilism. I won't call the ER. Nothing will change. The patient will be admitted. I'll be accountable for it. And it's helpless. But it's not. It's not helpless. There are, in a value-based model, you find shared incentives. Everybody wins. Patients win. The ED doc wins. They've made that disposition and they're on to their next patient, and they couldn't be happier. So it's just a matter of understanding the emergency department, understanding each hospital, and you really have to make a system. And I guess that's my big take-home message is leaders and PCPs make a system with the hospital so that they can identify patients, rapidly communicate, and that's how you build relationships. If I hear, oh, it's a ChenMed doc, oh gosh, I can probably move the person out of bed free. These docs are great. Then you have to make a system that it works for your patient.
So build a system that is sustainable, that is fostered around building relationships with the emergency room.
Shared incentives, absolutely.
And shared incentives. That's a great way to to finish our talk for today. Again, I appreciate the opportunity to be able to host this occasion. As always, Dr. Dan's company is great. It's awesome. And Adam, thank you for the opportunity for teaching us about how important this relationship is, with the emergency room in the care of the older adults. Thank you guys. Have a great night and great happy holidays for all of you. Thank you.
Appreciate it. Thanks so much.